Chapter, and Elaine is a consultant clinical psychologist and the lead for the Depersonalization Disorders Service. And clinically, Dr. Hunter has an interest and expertise in working with dissociation and childhood trauma within psychosis. So she's a visiting lecturer at the Institute of Psychiatry and regularly does conferences like that. She's also spent some time teaching CBT to clinicians in Uganda and Zimbabwe, and is the Sierra Leone lead for the Ebola Psychological Support Service. So we're really lucky to have Elaine with us today, and we're really interested in what she has to say to us.
Thank you very much for inviting me. I don't know what I'm going to say yet. Good, thank you very much for that introduction. And so today I'm going to be talking about dissociation and depersonalization. So I thought by first of all thinking a little bit about what is dissociation, and that might be something that you think you could answer quite quickly, but it's actually a little bit more complicated than it may seem at the beginning. So when we think about the DSM-5 psychiatric definition of dissociation, which I'm quite happy with in some ways, a disruption in the usually integrated functions of consciousness, memory, identity, or perception of the environment. You can sort of see that there's quite a few different bits, so you're already starting to think, okay, sort of integrated functions of identity, and what does that mean, opposed to memory and stuff. So, and then when you look a little bit more detail at DSM-5 dissociative disorders, you start to see some different categories. So we've got dissociative amnesia, so an inability to recall important personal information that is too extensive to be explained by normal forgetfulness. So chunks of memories that you would expect people to be able to remember. And that includes what's called dissociative fugue, which is where somebody suddenly takes off and does some unexpected travel, and there is an inability to recall one's past and confusion about one's identity, or sometimes the assumption of a new identity. I don't know that many people that do work in that area actually. It's a bit more of an obscure area. We need to start looking at that a little bit more. There's dissociative identity disorder, which has had a bit more of a kind of reworking recently, and that's about having the presence of two or more distinct identities or personality states, and I think that's a little bit more open to discussion and debate, because there may be that's on a continuum. If you think about how you behave in different situations, you might behave a little bit differently with your grandmother, or sort of afternoon tea on a Sunday, as you might do out with your friends on a Saturday night. And you think about the continuum of different ways that we might behave. I've actually got someone that I was seeing today, which is why I'll come a bit later, who were kind of exploring some of this of different states, and you know, she's kind of very frightened of being labelled this, but she does have kind of very distinct states and difficulty remembering things. So it's kind of accompanied by an inability to recall important personal information as well. But there's still I think it's becoming a more accepted diagnosis and condition, but it was very open to controversy at the beginning. Depersonalization, derealization disorder isn't open to really any controversy, which is quite good for me. I'm going to talk a little bit more about what it is, obviously, and get you to have a real flavour of what it's like. Here it's defined as a persistent or recurrent feeling of being detached from one's mental processes or body, but it's the really important thing to be aware of with depersonalization and derealization disorder, and I often forget to say this, so while I remember I'm going to say it, is that it's a totally subjective experience. So if you were talking to someone who says, I'm experiencing 90% depersonalization at the moment, you would not be able to detect it in any shape or form. And it's also accompanied by intact reality testing, so people know that this is wrong, that this is not how the world is. So they don't really think that the world is all foggy. They know that there's something wrong. Yeah? That makes sense. And that's where it is distinct from psychosis. Yeah? So they often use an as if. It's as if. Yeah? Anyway, I'll come on to that in a little bit more detail. So I'm going to talk a little bit about, so there's actually more to dissociation than is even in the DSM-5. If you think about all the things that could actually come under the umbrella, and that's a good way of thinking about it, different spokes. So in terms of dissociation as a kind of multi-spoked umbrella, you might want to think about the psychogenic amnesia that we're kind of talking about, dissociative amnesia, and dissociative identity disorder, depersonalization, derealization. There's also things like medically unexplained symptoms, where people have a range of symptoms, they've been tested, all sorts of tests, there's no physical cause for it, and sometimes that's seen as being a dissociative phenomenon as well. Out-of-body experiences, again, there's not that many people doing work on that. I've got a few people at the moment that have really they're in and out of their body during conversations and stuff, quite fascinating. Emotional numbing can be kind of part of the other aspects of dissociation, but people can just have that themselves, just feeling totally emotionally numb. Dissociative seizures that look a bit like epileptic seizures. I say look a bit like, they are sort of distinguishable, but only if you really know that area. Because people are often kind of still aware of what's going on in the dissociative seizure, whereas people with epilepsy tend not to retain consciousness. But they can look very, very similar. People can have both, just to make it more complicated. People with flashbacks with post-traumatic stress disorder, it's a kind of dissociative phenomenon. Conversion disorders, where that's the kind of old hysteria in Freudian terms, where people may have lose function of particular areas of their body, sight, for example, or particular movements that they can't do, and there is quite a bit of resurgence, I think, or maybe it's just like sharing office with somebody who works in conversion disorder. So I think there's a bit of a resurgence in it. So that's again seen as a kind of dissociative. And somatoform disorders, a bit similar to medically unexplained symptoms, but where people have physical health issues that don't again seem to have a biological cause. Just basically spacing out a bit. Trance and possession states, hypnosis is a kind of dissociative state, fugue states as I've talked about, and also I'm highlighting here that dissociation is not necessarily abnormal or pathological in any way. We all kind of dissociate a bit, and sometimes that's quite helpful. So one of the questionnaires, the most widely used one for dissociation, is called the Dissociative Experiences Scale, the DES. And actually the first question starts with about going on being on a journey and not being completely aware of the journey the whole way through. So you think about the last bus that you went on. Did you kind of go into thoughts, start daydreaming or something like that? So a divided attention or driving along. I've got another slide later on that I'll give some examples of that. So sometimes it's good to kind of focus and cut other things out. So if we want to really concentrate in the library, for example, revising, we don't want to be listening into everything, we want to zone in. So just to kind of, so when people, the reason I'm using this slide is that people often slip into a habit of talking about dissociation as though we're talking about one thing. Okay? That's what I want you to take away from this slide. And actually you can see it's quite complicated. And dissociation is one thing. Okay, it's a little shorthand, but it's actually, these are very different phenomena, and we can't do the same interventions with all these different things. So we really need to know what we're kind of talking about. So, as I just said, non-pathological dissociation, normal part of information processing. It's quite helpful to be able to drive and talk at the same time. I'm sure many of you have done that. And getting absorbed in a good book or a film, you become unaware of the environment, people around you. Yeah, being in a tennis match, just being in the zone or whatever. Yeah. And transient depersonalization, derealization are very, very common. Fatigue, or if you're a bit hungover, jet lag is another one that people often, or something that's been a bit shocking. You can kind of feel like everything feels a bit unreal, or you feel a bit unreal for a period of time. Yeah, if you're in a slightly shocked situation. And I've just mentioned that already. So in terms of thinking about some models, I'm not going to talk about these in any great detail, but just to kind of get you to see that there's different types of models of pathological dissociation we're talking about here. So most of them focus on the dissociation of personality. So the kind of more psychodynamic approach, fragmentation of the ego, that putting more and more stress and trauma, that the ego will fragment. And similar to that, there's a more recent one, Van der Hart and his colleagues, talking about how trauma can create emotional parts of the personality as well as different personality states. So you can see that kind of more DID type presentation. Someone that I work with, Fiona Kennedy, has actually taken a more CBT approach and looked at how using more traditional kind of Beckian ways of thinking about things has actually applied that to dissociation, and has written quite a lot about it. There's a book that I'll refer you to at the end. And talking about at different levels, so automatic information processing within the personality and between personality states. But I'm really just racing through these just to give you a bit of an overview, because I actually want to focus a little bit more on work that I've done with some colleagues, so you can kind of put that in a bit more context. There are also some that are more continuum models, and this one in particular, I'm going to show you a little diagram of this, which I think is quite nice. So it's talking about how dissociation can increase. So you might start off with the freeze, which is very, kind of took me a moment to kind of think about it, but if you see something that you're not sure of what it is, or something that sort of, you will sort of just stop and orientate, and just, it might just be for a second or so before you start reacting, but you're just watching to see what this is it danger kind of thing. And then you might get the flight and fight response, and then going into fright, flag, and faint. So they talk about, this is a useful paper to have a look at. But this is a kind of continuum model, so saying that all these different phenomenon are on a continuum of this sort of same thing in a way, and they're just at different stages. So I, quite a while ago, as you can see, this was 2005 that we published this paper, but there were quite a few of us that got together in London that were interested in working on dissociation. And basically this paper came about because when we all got together and thought we were talking about the same thing, we realised we were all talking about quite different things. So, as people like, that's Richard Brown, there's a few Richard Browns, as you might imagine, but this Richard Brown, who does quite a lot on conversion disorders. I'm really talking about depersonalization. Oakley is more into hypnosis, and so, we realised that we were actually all talking about different things. And we came to this is the title of the paper, they're two qualitatively distinct forms of dissociation. So actually when we reviewed it, we kind of thought that it can break into two quite simple categories. So there's types of dissociation that fit within this compartmentalization. So this is where things that have been compartmentalized, whether that's physical functioning, whether that's memories, whether that's aspects of the personality. Yeah, follow me? Okay. As opposed to detachment, which is this kind of sense of separation. But you can have the two things together, so they're not mutually exclusive. And so I'm going to talk a little bit more about detachment, because that's more my area and field. So in this paper we talked about it being a separation of detachment from different areas, including. So there's a kind of, what we talked about is that there's two continuums. There's a continuum of compartmentalization and a continuum of detachment, rather than putting everything on the same continuum. Because you'd work with things in a very different way. So most of us on that list were academics and clinicians. So we're also thinking, well, we wouldn't, things are very different phenomena. The treatment's really important. You need to know what you're dealing with. So I'm going to, this is a client that again I worked with a little while ago, who gave her permission to use this, and she's also in a book chapter. She wrote a slight bit longer than this, but we've edited it. But I just want you to get a flavour of what it's like to have depersonalisation. So she talks about, I feel lightheaded and things around me seem strange and unfamiliar. My arms sometimes feel like they don't belong to me. I often have the sensation of being very tall or small. I experience life as though it's projected onto a screen and not actually happening to me. That's very important. That one is a very common one. I have odd physical sensations, the experience of being divided in two. My head feels like it's crammed with cotton wool. My hearing strangely muffled, like listening to sound underwater. Distances are exaggerated, as if I'm looking down the wrong end of a telescope. Incessant probing thoughts continue to bring the existence of everything, including myself, into question. Again, that's a really key symptom. Feeling fragmented and disjointed, overwhelming impulse to strip meaning from all things. My increasing detachment is accompanied by a kind of all-pervading numbness, making it hard to connect with people and the real world. Next time I do this talk, and next month I'm doing making a kind of little mini documentary with people that have experiences of depersonalisation and recovery from depersonalisation. Hopefully I'll be able to add clips in next time. But there's, I suppose, some of the key symptoms are the sense of unreality and detachment. So people often talk about it feels as though there's glass or fog between them and the world. Physical and emotional numbing. Emotional numbing is very predominant, but that's for, it's a bit of a disconnect in some ways, because they'll often say, that they're really distressed by things, but they're also numbed from it. So they're kind of aware of this being very distressing for them, but they also talk about that they can't really feel that emotion in a kind of embodied sense. And the physical numbing, sometimes people really can't feel any part of their body at all. It's like a local anaesthetic. Lots of sensory impairments, as you saw in that bit with Carol. So sound, taste, colour, boundaries, visual disturbances as well, distortions, things looking 2D, impaired cognitive processing, it's just difficult. And the terminology, depersonalisation relates to the self, derealisation is the external world. And now DSM-5 has updated that so that they're both, because usually they co-occur, but the distinction's a little bit technical. And depersonalisation disorder is where it becomes chronic, distressing, and has functional impairment. I'm going to not take too long over these. So we've got the epidemiology. So people in non-clinical samples, it's actually very common to have transient symptoms. As I said, dissociative fatigue, substance misuse, trauma. So there was a kind of phone survey, a very well-designed, randomised phone survey where people just asked if they'd had these particular symptoms, and 23% said they'd experienced it over the last year. And then actually when you do representative community samples at current clinical significance levels, it comes to usually around about 2% on average. There's quite a few different samples. the average being about 2%. And in other psychiatric conditions, it's very, very common, but particularly high in anxiety disorders, especially kind of panic. And in fact, depersonalization to derealization are two of the symptoms of a panic attack. When you look at the DSM criteria. We have now seen about 500 or so people in the clinic now. There were also a US group, and so some of the early seminal papers were kind of from our group when it first started doing a lot of research, and the US group as well. Pretty much men and women equally, it's not a gender specific. Often sort of young adults. It's the kind of, I mean, it can happen at other ages, but young adults are very common. And there's kind of often three patterns of onset. The trauma people, especially if it's childhood trauma, it tends to have been there most of their life, and they haven't got a particular onset. There are other people where they have like short, intermittent, and those episodes, and those get longer each time. And there's other people where it literally just switches, and that's it, and they've got it, and it's chronic from that point. So those are the three patterns. And then lots of different things that cause it. Drugs is quite a common cause. Actually, I need to probably update this a bit. I would say there's three causes. Trauma. Drugs don't necessarily cause it, because people can get it without any drugs, but drugs might trigger that reaction. The other one is anxiety states, probably the number one. And that's another take-home message. People mistakenly think this has to be with trauma. Lots of people get depersonalization, they haven't got trauma history. They usually have anxiety history. So very high anxiety and depression scores in these samples, in the phenomenology papers. And the other thing that's quite interesting is that they don't tend to have the dissociative amnesia. So, and actually, there's been some other groups that have looked at the split between the detachment people and the compartmentalization people, and they do tend to split out. So you can get groups like PTSD, you might get both things co-occurring. Yeah. And so historically, there's always been this close link between trauma and dissociation, and that certainly people that have had a big trauma history may well have dissociation. I won't take much longer over that. And now we know that lots of people with childhood abuse histories, but it tends to be a bit more towards the compartmentalization types of dissociative disorders. And those associations are not found in primary depersonalization disorder. So people that just have depersonalization disorder don't tend to have, lots of researchers went in looking for different types of trauma and just kept hitting a brick wall and really not finding it. There's a bit about emotional abuse, but really it's quite low level. It's not capital T trauma. It might be slightly more insidious. And there's often no history of trauma at all, but there are these very strong links with anxiety. And in fact, we were lucky to access a database, a very interesting one, where it was called a birth cohort. So everyone that was born in the entire country had been followed up over their life. And we were able to look at that cohort, which is why it's a nice big number. They had had a full psychiatric interview at age in their 30s. And we were able to look back at predictors of people having depersonalization in their 30s. And it was anxiety observed by teachers at around age 13, the only significant predictor. And people often feel very terrified when it starts. They obviously have no idea what's going on. You've seen the range of symptoms. It's kind of quite puzzling, isn't it? It seems to be all sorts of strange things. And there's a bit of a kind of matrix phenomenon of it. It's almost like that moment when you suddenly see the world in a completely and rather scary way, and comorbid with anxiety and panic. I'll just run through in the last slide a bit about the overview of how you might work with depersonalization and derealization. One of the key things is actually going through and giving people some education about it. I mean, one of my roles in the clinic is to come and give talks like this, so people learn a bit more about it, and to increase public and professional awareness. So often people go to their GPs, the GPs don't really know what it is, so we've got a paper that's going to be coming out to hopefully address that in British Medical Journal, which is a kind of quick guide for GPs to kind of know what, to recognise some of these things that people may be saying in a quite tentative way. Quite sure how to explain that I don't really feel like I exist and the world doesn't seem like it's really real. It's quite difficult to kind of put into words. So making links to their personal history as appropriate, as to what mapping out what seems to have led to the depersonalization starting, and then also what's keeping it going. So often there's a bit of a vicious cycle. I've got the late slot today because I had an assessment come in. She was extremely typical, where a lot of worry, anxiety and worry, led to the depersonalization. And then she now has a lot of worry and anxiety about the depersonalization, which then creates more. And she said, she's just got into this kind of loop that she can't get out of. So shared formulation. We might get people to kind of keep a bit of a diary to see if there's fluctuations that we can then manipulate, to see what makes things better for them, what makes things worse for them, and try and modify those, and actually trying to help them cope with those symptoms a bit more. Working with related anxiety and depression, because the three often are like three Venn circles. There's depersonalization, anxiety, and often depression subsequent to it, when they feel hopeless that things are ever going to get better. Looking at their cognitions that are unhelpful, fears about the depersonalization, and also working quite a lot with the thinking processes. So the key thinking processes will be kind of rumination, attention focus. People will, it's like taking a thermometer. What's it like now? Is it any better now? People will really get completely sucked into it being everything, and drop doing things. So really trying to break some of that, help them shift their attention onto other things rather than this kind of symptom checking, and dealing with the kind of unhelpful behaviours. The checking may be part of that as well, and avoidance of certain situations. And looking at the factors that then, once we've worked a bit more in the here and now, people are feeling a bit, the depersonalization is better, or they're learning to cope with it better. Because I can never say to people it's going to definitively get better. I want to manage expectations at the beginning, and talk about how they hopefully will there will be less fear involved in it, and it's maybe about managing it. And usually the pattern of people getting better is that in it becoming less of an issue in their life, it actually then starts to, and they kind of talk about how they then become aware, I haven't really felt it, I haven't really been aware of it. And that's generally how people get better. There are some people where it literally just switches off again. And I suppose the metaphor that I use with patients to talk about it is that it's almost like a trip switch. So think about it like an electrical system, electrical circuit. You keep plugging things in, more and more goes on. At a certain point, the trip switch might just trip out, and at that point, everything is detached. And we're just numbed out, detached from everything. And that seems to ring true with people. So there's a bit of, that's actually not the cover, but that's the only picture that I can get from Amazon. There's an Overcoming Depersonalization and Feelings of Unreality self-help book. And then this is the Cognitive Behavioural Approaches to Dissociation. It has got different chapters on different dissociative phenomena. written by professionals for kind of professionals or people interested in the area. And if you're interested in coming and doing anything at the Depersonalization, you're extremely welcome. And that's it really. Thank you very much for your attention. And I think if we've got a minute to take some questions, where I'm running over as well.
Yeah, thank you very much, Elaine. That was really interesting. Does anyone have any quick questions?
Sorry, I don't want to jump in again. Something
Yeah.
else. I imagine it could be a protection mechanism, but I would have thought one of the things that could be very difficult for somebody is when they talked of conversion disorder in the past, in a Freudian sense, it was criticised that people talked about sexual experiences as being false memories. But I can understand in dissociation that you could think it was a doubt yourself and think, did this really happen? Did I dream it? And unless you get the reinforcement from somebody and saying, actually, this did happen, you then going around doubting yourself and thinking that you're in some fantasy world, that you've got this fantasy that something might come back, a memory. How do you, without somebody saying to you, you were in this context and this happened, how do you work out whether that was a dissociation or a false memory?
Okay. You're actually talking to someone who did their entire PhD on memories of childhood sexual abuse. So it is kind of an area I know quite a lot about. And I think what you're doing is actually mixing up two completely different things. We're not really talking about memories of sexual abuse or anything in here.
I'm not talking about sexual abuse here.
Sorry?
I'm not talking about sexual abuse here.
Yeah, it seemed to be that you were talking about false memories and...
Yeah, because I mean basically if you dissociation you zone out. I mean we know that borderline personality that you can dissociate. Post-traumatic stress.
Yeah.
Actually I asked because I was a police officer and
Yeah.
I've had situations where I myself have been in a situation and I'm not sure whether it's actually a dream or whether it was reality.
Yeah.
And without actually saying to somebody, did that happen?
Yeah.
Then I've got no way actually finding out whether that happened. So that's the reason why I'm asking. It's not sexual or anything to do
No,
with
no,
that.
I'm not quite sure what your question is.
Because if you start to think of false memories, it's kind of, a lot of people discredited that, but you can understand sometimes in dissociation that you might get little things coming through to actually filter through that when you were dissociating, you remember certain things that it did actually happen, that things were actually happening,
Yeah.
and that might cause self-doubt. Can you see?
Yeah, so actually in my PhD, as I said, it was about, so I looked at a big sample of people that had reported that they'd been abused as children. So they'd obviously at some point remembered it. And it was really looking at the factors that influenced whether people had always been able to remember, had significant memory impairments, and looking at those things. And dissociation was one of those factors. People that dissociated at the time of the trauma. And I mean, if you are dissociating at the time of the trauma, there are other mechanisms as well that can also, denial as well can actually influence whether you doubt whether it actually happened to you or not. And there are kind of, still don't think I'm answering your question.
Well, partly because it would be a traumatic incident, which is a protection mechanism that you could slip into dissociation. My point is, how would you, without actually having somebody else tell you that when you're in that situation, this happened, if you start to get filtering memories through about an incident, how would you tell yourself that it actually did happen rather than being a false memory?
I'm not really sure I agree with the false memory side of things. I think that most people that recover memories, unless they're in a situation where people are because there was also a working party that came about that actually looked at memory recovery processes. Most people that recover memories of what happened to them will be doing it will be quite, I think, genuine. If they're not having hypnosis or really trying to regression therapy or anything like that, most memories will come back to people. And are you saying that how does that person know whether they're genuine or not? I think the majority of people do know whether they're genuine or not. It's some people might slightly doubt it if there's things that are, and sometimes those memories come back at the beginning with a very kind of felt sense. As I said, I'm discussing this. My office colleague was assessing somebody yesterday on the conversion side with exactly this. They felt that their stepfather always felt a bit uncomfortable with them, but actually they were then able to actually come up with quite a few things that probably were real. So people may doubt things that have happened to them, but I don't think it's as big a phenomenon as the false memory people kind of like to purport. Does that make sense?
Yeah, it could be
because you have to understand how the false memory kind of started, and it was really by parents that had been accused by their children, and they were a kind of advocacy group to say these are false memories, and they were drawing upon research from analog studies of how people can make mistakes in their memory, and we all know memory is very fallible, and they were using that. Where in trauma situations there are lots of other examples of situations, like in the First World War, war veterans, where they have periods of amnesia of what's happened to them, but no one actually says, well, I don't think you were at that battle or something. People don't question it. So you have to. It's quite a complicated thing to try and understand what's going on with it. Unfortunately for me, people talking about false memories. I try and suppress it, but it's a bit of a red rag to me. I kind of find it because they're usually people that haven't dealt with people that have really had a lot of trauma. And actually most people, when they talk about how the memories have come back to them, or most people always remember actually what happened to them. Or if memories do come back, they tend to come back in a very, a way that a non-professional wouldn't know how to, they probably haven't read up on it. But there are kind of quite a lot of patterns of the way that memories might come back to people. I don't know whether that's answered a bit more. Is there anything else, or are we done? Anyone else got another question? Yeah.
You spoke a little bit about working with people about dissociation.
With depersonalization.
Depersonalization.
Yes.
Do you ever work with younger people or have noticed?
I don't actually, because in the NHS there's very clear child services, adult services. So I haven't really. Was there a particular thing that you were wanting to know
I was
about?
just thinking about if you have examples of how you might work with a younger person. So obviously you don't personally, but
yeah, I don't. I mean, there is actually quite a few. It's something that I've talked about because we've actually got quite a few people that are like 16-year-olds that are really have very severe depersonalization, and when the adults is defined as 18. So I have been asking maybe we could do some work on those. I don't think at that age I don't think I necessarily have to adapt anything. But I don't know, and I don't know how much depersonalization is seen in younger children. There might be other dissociative phenomena. Actually, something to say that dissociation generally is higher in children. So if you look at normal samples, we all dissociate a lot more as children, and then in adolescence it drops down, and then in adulthood it drops much lower. And that's because if you look at children playing, they're really they really are a cowboy at that moment, or they really whatever. So it's that there seems to be a tendency that eventually kind of we just lose a bit over as we move into adulthood. There was another lady there.
Yeah, because you said sort of have to give education to like the GPs so that they acknowledge that this is a thing.
Yeah.
How do you actually get treatment for it? Like, if you don't tell your GP, or if your GP doesn't understand it, what's the process of getting treatment for it?
It is really difficult actually, and some of the people that, I can't remember what the average, it's either 8 or 12 years that people took before getting symptoms to actually getting a proper diagnosis.
Yeah.
It's just unacceptable really, isn't it? That people, it really depends, and so we've had a big article in The Guardian last September, which lots of people saw. It was a big, a whole page, people talking about their experience and stuff. We really do need to educate, because the GPs are the gatekeepers.
Yeah.
So trying to get, so this article with actually the person that was in the Guardian article is going to be co-author on this paper, talking about what it was like for her, trying to explain to a GP and her journey. But we're also hoping to try and get something sent to all GPs with sort of something that they can stick up on their wall somewhere. Because and in this article we're going to put some ways that people might typically try and explain what's happening to them. Because I've said, oh, this is what it looks like, but actually people really find it difficult to articulate it. And it's an unusual condition in a way that the checklists are very helpful for people. They're going to go, oh yeah, that's exactly it. And the classic thing is that people say that they didn't really know what was happening, they kind of Googled something, and then when they see the whole syndrome outlined, they're like, oh, that's me. I didn't know what it was. They often end up, sadly, taking it to the GP.
Yeah.
Or GPs Googling it. That's what I heard this afternoon.
May I add? Yeah, because I have actually, I don't know if this is too personal for like the room, but I do experience like a lot of it.
Okay.
And it has been going on for a few years.
Yeah.
But I did have like depression, and I think I still do, I don't know. But I did try to like tell a few GPs and even the counsellors and everything, and they sort of not acknowledged it, and instead I got prescribed for just depression. And I think like the main thing is, for me, it's actually this one, like, and not the depression, because sometimes I think at this stage, don't worry about me, but at this stage it feels as if sometimes the detachment is so strong, and I don't acknowledge my body, I don't feel it, to the point that I would self-harm, because it feels like it's another person's body, or it's just a body that's been given to me, I have to take care of it, and I just don't feel it, and I'm trying to make associations, and it doesn't really happen. But yeah, I think no,
I mean, it's really sad, your story. It's exactly what
I know. I was
and
listening to
you can see that. I can almost picture them, going along, and they see someone and they kind of go, okay, I know about anxiety, I know about depression, don't know what this other thing is.
So they treat.
So I'll help them with these, and we keep ignoring this other thing that they keep talking about. I can see clinicians trying to do it and trying to do their best. The other thing that I realise that I really need to get into the IAPT training. Do you know what IAPT is?
They have talked about it, yes.
So it's the kind of primary care level of psychology, so that people are a bit more aware. So I have an enormous amount to do in terms of professional and public, but it also comes very well from people with lived experience. So like the woman who can put herself out there in The Guardian, she's got a big picture, she's talking about her experiences, and other people, and this film that I'm making that is actually being made by somebody who's recovered from depersonalization himself, who happens to be a filmmaker. That was success, wasn't it? When I suddenly went, oh my goodness, you make films, do you want to do? So, and so, make those sorts of things and getting those much more public awareness. Also, Will Young has said that he's had depersonalization, so we're hoping to kind of harness him and try and get him. Sorry.
Oh no, it's just saying. No, my brother loves Will Young, that's what I have to say. He spoke to, because my brother did some stuff for mental health awareness and went to meet with Will Young. And he actually spoke about that with his which is really
Exactly.
interesting.
We're like, we've got to get him on board as the front man. Who doesn't like him? He's a nice guy. He'd be great as the front person. So, you know, we need to do a lot more of that because I think it is there and it's really hidden, or it's misdiagnosed or mislabeled or something. So, please, there is on the Maudsley website. There's a whole page about what we offer at the clinic and stuff. There are people that are doing work, that do get informed and do read up on it. So, I mean, I have, that book was quite recent, and that is a nice sort of step-by-step guide for clinicians to be able to read. It bothers me that people can't get help for it.
Yeah, me too.
Yeah. Okay. Is there anything else? Thank you very much for sharing that.
Thank you.
That's really kind. Yeah. Anything else? No. Okay. Thank you very much.